Good. Okay, I think we'll get going. So welcome everybody to our webinar this morning. For a number of years, insurers have augmented their products by offering additional services to their policyholders on the life insurance side. For example, services like second medical opinions or virtual general practice doctor's appointments or engagement apps that interest policyholders and hopefully reduce policyholder lapses have all been popular over the last sort of 5 to 10 years. And often these additional features aren't necessarily directly related to the insurance, but they're just sort of an additional service to engage policyholders and to add value. And if that's the case, then there's no real need for reinsurer input. However, for some time, we've been interested in additional services that are linked to the underlying insurance risk as the risk carrier. So as a group, Hanover has been a thought leader in investigating the potential for wearables and predictive genetic testing. And not only do these things have potential to engage customers and increase sales, but also, if used in the right way, they have the potential to improve the health of policyholders and ultimately potentially reduce the need for policyholders to claim on the policy. Today, we'd like to share some details of a pilot that we did in combination with Alula and Ali Health to assess the potential of developments in healthcare monitoring technology. So I'm joined by our chief underwriter, Gareth Matthews, who will give us some background on the healthcare landscape. Following that, we've got Simon Spur from Alula Technologies, who specialise in supporting life and health insurers with business critical solutions, improving process efficiency and integrating third-party data. He'll be speaking with Kelly Cleafer, who's CEO and co-founder of Ali Health, a company solving the last mile of healthcare with their tech-enabled platform, bringing clinical care to patients' front doors. They will discuss the developments in healthcare technology and how this can be integrated with traditional services to give holistic health solutions. I'll then speak briefly about the applicability of this to the life insurance industry. And finally, we'll have a Q&A discussion with all the members of the panel. And for this, we'll also be joined by Lisa Balboa, who heads up our Hanover's Digital Business Accelerator and leads Hanover Re's Global Innovation Network, focusing on harnessing digital and innovation to create value for our life and health insurance clients. So we would welcome your questions for this Q&A. You'll be able to submit them via Teams at any point during the webinar, so please do that and we'll feed some of those into that discussion. For now, I will hand over to Gareth to set the scene for us.
Thank you, Tim, and good morning, good afternoon, good evening to all of you around the globe. Thanks for joining us today. As Tim mentions, I'm going to kick us off with some scene setting before handing you over to the Alula Technologies and Ali Health team. So until quite recently, we've seen consistent increases in projected life expectancy at birth, with higher numbers of people living longer. The paradox of advances in medicine, sanitation and such is that people are living longer, but often with now manageable chronic diseases, with more than 1/3 of people living in the EU identifying as living with a long-standing health problem in 2022. And we're seeing sustained pressure on our health service for a number of reasons. The chart on the left here illustrates an acute on chronic problem insofar as there is increasing morbidity requiring extensive care, but a current inability to service emergency care patients promptly is having a material impact on deaths. And even before we start to consider demographic changes, when you consider there are half as many hospital beds today than in 1988, yet the population has increased by over 10 million, it's quite easy to imagine the strain our NHS is under. The Royal College of Emergency Medicine illustrates the impact of A&E waiting times on mortality, with any delays greater than around 5 hours equating to a higher rate of death than would otherwise be expected. And NHS data for England shows more than 1.5 million patients waiting 12 hours or more in major emergency departments in 2023. And we see this quote here on the top left from a recent BBC article that estimates around 250 unnecessary deaths per week in England alone due to A&E delays. The reasons for widening healthcare gaps, we've touched upon some, but the chart on the right here illustrates that in addition to society aging, we're seeing increases in chronic diseases that are often self-inflicted through increasingly sedentary behaviours and poor diet, particularly an over-reliance upon processed foods. Longer waiting times, not just for A&E, resulting in delays in diagnosis and treatment, impact disease burden across all severity levels. And there are considerable barriers not only within frontline medicine, but also in adopting and embedding new treatments and tech, which could result in significant improvements in disease outcomes. But what we're also seeing, however, is a steady democratization of health management through technological advances that have transformative capabilities. We're seeing an increasingly curious public able to self-source medical information through the internet. And while society is aging, digital natives and digital competence increasingly spans protection-relevant age groups. The expectation of service provision versus the plain transactional relationship historically seen in insurance is also growing. So the question we must ask ourselves is, what opportunity does that leave us both to expand our offerings as insurers and also reduce the societal burden illustrated? Next slide, please. So we've just picked on a few morbidities here, some key ones, both in life and in insurance. But in truth, the incidence of most non-communicable diseases is influenced by the lives we choose to lead. Around 40% of cancer incidents can be prevented through risk modifiable behaviours. Around 1/4 of people in England experience a mental health issue annually. And more than half of the UK population will get cardiovascular disease in their lifetime, with a significant proportion undiagnosed, which in itself represents a pretty significant opportunity. There are multiple ways to influence our health, but looking at exercise alone, take a look at these stats here from the Lancet. Compared to inactivity, exercising just 15 minutes per day reduces all-cause mortality by 14%, and each additional 15 minutes of exercise per day further reduces all-cause mortality by 4%. The slide asks if prevention is better than a cure, but the benefits of exercise are also seen after diagnosis, with 15 minutes of exercise per day reducing mortality by 20% in those with known cardiovascular disease. So what can we do as insurers to influence more proactive management of our customers' health? Can we take a more holistic view of customer care than the traditional insurer-insured relationship? And this is where I hand you over to Simon and Kelly of Alula Technologies and Ally Health.
Thanks very much, Gareth, and a big hi to everyone who's joined us on the call today. So Alula is a global technology company with headquarters in the UK and having operated for more than 20 years in the Southern African markets. We focus on integrating rich data insights into our modern technologies to unlock efficiencies, drive better decisioning and engagement for our customers and partners across the health, insurance and employee benefits verticals.
Hi everyone, so let me tell you a little bit about Ally Health. At Ally Health, we have developed a platform to enable effective clinical care at home on demand. Our solution for the last mile of healthcare improves accessibility and health outcomes, as patients can now conveniently access care outside of clinical settings. Our B2B model easily embeds into healthcare providers' existing flow thanks to our suite of API endpoints. When it comes to delivery of healthcare itself, we have developed comprehensive and efficient clinical pathways to cover a breadth of clinical risk factors, most relevant for today, cardiovascular risks. Our real-time availability algorithm enables us to then optimize the way that practitioners work in the community and deliver both routing and workflow efficiencies. I'll hand it back over to Simon to tell you a bit more about the Viva's core solution.
Right, so if you look at the slide, I'm going to talk to it from left to right as you see it on your screen. So if you can just click for the animation to play. The underlying data platform, which is Health Cloud, aggregates various disconnected data sets. So what you're seeing on the left-hand side is the ability to be able to draw and harness data from multiple disconnected places. The data types encompass wearable devices and RPPG face scanning capabilities, while also incorporating data from blood tests and other connected data sets. The platform can ingest data really from any compatible third-party source, be it an insurer's own data, clinical and medical systems, and service provision partners. In the South African market, by way of example, we have extensive integrations into electronic health records, pathology labs, and clinical systems, and thereby offering a bilateral data exchange for both health and life insurers. This data collection happens in real time via a sophisticated API layer, which structures and normalizes and consolidates the record. And then at the core, what you see in the center of your screen is the core of our engine, which is the algorithmic process, which calculates a unique and personalized score for every end user. We aim to collect verified and validated data and thereby minimize self-reported information to enhance both the objectivity and accuracy. Currently, within the algorithm, it's able to understand 61 different data points, and these can be configured per client or integrated partner. This platform itself has generated more than 6 million unique scores to date. And then shifting to the right-hand side, so the solution sitting at the front end of this is VivaScore. This is available as web native mobile apps for iOS and Android and Microsoft Teams apps. Our VivaScore, with appropriate consent measures, surfaces up all of the user's data in a highly engaging way. Users can connect to their favorite wearables or their health tracking applications. They can take digital health checks using RPPG embedded technology and receive intuitive nudges that help steer them towards optimal health. The user's score will update daily based on the availability of fresh and new data through the system. And alongside that is this capability to generate personalized reporting. The user or end user in this case is able to receive insights into their score, along with tailored suggestions or improvements based on the measured health metrics. The group, be it an insurer, employer, or healthcare organization, also receive an aggregated anonymized reports on all users in their base. If you transition the slide, I'm going to hand back to Kelly.
Thank you, Simon. So as part of this partnerships, Alula's VivaScore users have access to our live booking function via the VivaScore app, which enables them to book their health check appointments on demand. On the back of that, we feed the collected health data, so that includes bloods and biometrics data, back to the Alula team, and that allows us, as Simon has mentioned, to update the risk grading of each patient in a very dynamic fashion. If we could move on to the next slide, please. So, thank you. With the partnership between Ally Health and Alula, it is really rooted in the belief that combining digital health and clinical health data can be a really powerful tool to assess population risk factor and drive behavioral change amongst service users. From a digital health data perspective, on the one hand, that enables us to have really continuous health tracking and high degrees of engagement amongst the population, which in turn delivers really effective risk stratification at scale. When we turn to the use of clinical health data, we are then able to deploy that as a targeted approach for further in-depth health checks amongst a smaller subset of a target population. We can augment the digital health data that we have collected with biomarkers insights, such as cholesterol, for example. And that in turn allows us to provide really highly reliable data to further inform the risk grading and the data-driven decision-making for insurers. I'll hand over to Simon to tell you a little bit more about the pilot that was delivered here.
Thanks, Kelly. So in the pilot, the exam question we set out to answer was whether wearable and RPPG data, when integrated with in-person healthcare services and blood testing, has the potential to reduce the need for many confirmatory tests. Furthermore, could this streamline the underwriting process with a better understanding of health status and/or risk, both early on and during the policy life cycle? The challenge we aimed to address using the technology was consolidating all of this data, interpreting it, applying intelligence and insights through our scoring, nudging, and reporting capabilities, and then presenting it to the end user in a highly engaging manner using the VivaScore app. Similarly, insights into the pilot users were presented to Hanover Re through a rolled up group report available on a weekly basis. Now, the pilot itself ran for 12 weeks, as you can see, so November through to January. The users were asked to set up their application or download and register their profiles. They were able to connect to their favorite tracking devices or connect their wearable device. They were also able to engage in regular digital health checks using our embedded RPPG capabilities. And then following that, we're able to actually book their appointment with an in-service blood testing capability through the Ally Health platform. The nurses took blood tests early on in the pilot, and through this, the users were actually able to build a score and a deeper understanding into their health profile. All of that information was surfaced up to them in the application and the reporting as I described. So just focusing on some of the key metrics that we tracked throughout the pilot, biometric information and blood testing was gathered through the nurse service in person with the pilot participants, and then multiple metrics gathered through the wearables and the RPPG capabilities using our technology, which focus on activity as well as mental health metrics. Now, just in terms of the key objectives, so really what we set out to do was supporting both the individuals in terms of the pilot users being able to use our secure technology, build their own data and connect that data to be able to gain greater insights into their health and be able to track their own scoring and insights into that, as well as then use this information to make lifestyle changes where and if needed. And then in parallel, really to support insurers and reinsurers in the case of Hannover Re as our partner in the pilot to A, understand their risk more accurately, B, be able to engage with policyholders more effectively, and then C, lastly, keep the policyholders healthier for longer, ultimately in a cost-effective way. If you can transition to the next slide around the actual results and insights. So the engagements, I'm not going to talk to all of the stats. There's quite a lot of information on the slide, but we saw really good engagement through the pilot process during the 3 months. In particular, really high engagement on the digital health check capability. So users on a regular basis taking their own face scans and generating their own data from that tool, with more than 90% actually completing a digital health check every month. In terms of user feedback, we saw really interesting information about people surfacing up new information that they weren't aware of before about their health. And then a good proportion of users actually reporting behavioral change. So a positive impact in terms of what they've learned from this process and then applying it to their own health, which for us was really valuable. And just in terms of the actual reception, I think from a technology perspective, the users found the VivaScore application easy to work with, easy to use, particularly in terms of being able to connect up to their wearable device and then being able to participate in these digital health checks, as well as the reporting and the insights that we provided to them as really supporting information. And then I think focusing on the impact in the insurance vertical, really from our perspective, was by integrating wearables alongside regular digital health checks and this monitoring changes in user score, we believe can build a more comprehensive triangulation of risk. Over time, the data could be used to activate interventions at thresholds established by the insurer or the reinsurer. These interventions could provide blood tests or in-person health checks to those with higher risk scores, as an example. Proactively identifying these high-risk individuals and then directing them towards medical consultation or intervention could improve long-term health outcomes and potentially reduce claims. Ultimately, this could increase engagement for the policyholders, but also offers up the potential to develop more personalized benefits and plans, better risk assessment, and ultimately a proactive approach to health and wellness. Thanks. I'm going to hand over to the next slide.
Great, thanks, Simon. Thank you, Kelly. So I'm just going to talk now a little bit about what we see as the potential here for integrating this technology into life and health products. There are 3 key areas that we've picked out here where we think there's significant potential. The first and maybe the most obvious is in underwriting. So some of this technology can be used to make the underwriting process more thorough, more efficient, or possibly to replace some of the things that are going on at the moment. So in particular, things like the face scanning ability, using the statistics from that could help replace medical screenings for some individuals, or allow us to increase automatic acceptance limits. And that's something that can be really done at point of underwriting, quite simply with somebody just using the camera on their mobile phone for a sort of 30-second video selfie. So it's quite easy for the policyholder to do, and quite a lot of data collected. It's also possible to integrate data that people might have already based on wearables that they have been wearing or something like that, and bring that into the underwriting process. So there's definitely significant opportunities there. A second area that we'd highlight is in-force management. Here, I think what we're looking at, or our interest is focused on the possibility of rolling out this technology fairly cheaply amongst an in-force book of business, and using the technology to triage those who potentially could benefit from further medical interventions. So this again might use the face scanning technology to identify the most at-risk policyholders who potentially have conditions that maybe they're living with and don't really know about yet, haven't been diagnosed, and then triage those for further tests, either integrated through the technology or advising them to seek healthcare elsewhere. And this has big potential to quite cheaply identify the most at-risk policyholders and get interventions before these conditions develop severely and obviously ultimately lead to a claim. And the third area that we'd highlight is kind of a combination of these. It's the sort of ongoing engagement model. So in the way that some insurers have looked at doing this in the past, it's using the technology to engage with policyholders, get them to engage with their health, either with incentives, with rewards, with discounts in premium for those that are engaged, and sort of give them valuable feedback on their health status and what they can most effectively do to improve their health and ultimately reduce their risk as a policyholder. So now we're going to move on to the Q&A discussion. And as I said before, please feel free to submit any questions that you might have through the Q&A function in Teams, and we will tackle those along the way. And have an interesting discussion. So perhaps first, if we give some thought to, I guess, the accuracy of this technology. So I mentioned one of the key things that we tested was this face scanning technology, where you take a 30-second video selfie and you interpret the results of that to try and get an indicator of somebody's blood pressure, somebody's heart rate variability, quite key measures that could tell us a lot about the health of the individual. But obviously, none of that is very valuable to us unless the results we're getting out are accurate, and it's a good measure of somebody's blood pressure, for example. So maybe Lisa, if I start with you, how can we establish the accuracy of these technologies so that we can be confident when we're using them in pricing and in underwriting?
Yeah, thanks, Tim, and really enjoyed all the insights shared so far. So I think the accuracy question is a really important one, particularly if we're looking to go beyond the customer health engagement piece and actually perhaps do some underwriting or do some pricing of customers based on this technology. So as you can imagine, from the Life and Health Digital Business Accelerator point of view, we've been looking into some of these providers, and a lot of them do make available some of the research that they've done to try to get comfortable with the accuracy of this technology. So where we've looked into this, typically what we've found is up to now, these providers have focused on establishing the accuracy for healthy lives. So what might equate to standard risk customers in an underwriting point of view. So already that's quite interesting. If we can find some features, maybe things like heart rate or heart rate variability, where we think for healthy people, this technology is accurate, that could open up some pricing opportunities. So the sorts of things we've been exploring is, can we use this technology perhaps to offer a preferred lives discount or some sort of reward or incentive to those healthy customers that maybe have the best heart rate or the best heart rate variability? Because when you look at the literature, there is a correlation between a good heart rate and lower mortality. So that's already quite an interesting finding from the pricing side. Then thinking about the underwriting, of course, from a medical underwriting perspective, it's a high bar to then think about, is there a possibility to replace some of those more traditional medical underwriting tests? So perhaps things like the blood pressure checks, things like blood cholesterol checks, where again, the RPPG, these video selfies, are starting to give some insights into those measures. But is it accurate enough to actually replace some of those traditional medical underwriting tests? Or even, as you were talking to, Tim, maybe even segment some of those customers into the higher risk versus the lower risk based on these tests. So what we're doing at the moment is we're actually doing a study to look into that question. So we're working with some partners in one of our markets to actually do this video selfie, this RPPG scan, alongside the traditional nurse testing. So the nurse would take the blood pressure reading, the blood testing in the usual way, and at the same exact time, they would undertake that video selfie, that RPPG scan of the customer, and then we'll have that data collected, particularly across a range of demographics, also across a range of ethnicities, so we can really drill down into that data and see, is there some potential for some of these measures to be accurate, either to replace traditional medical underwriting or even as a first way to risk segment customers based on some of this medical information. So yeah, we're really looking forward to finding out the results of that pilot later this year as well. Sort of conscious as well on the underwriting side, Gareth, you might have some inputs around the potentials in this space that you want to add as well.
Thanks, Lisa. Yeah, I think the potential for disruption in the underwriting space is really quite significant. There's been upward pressure on non-medical limits for as long as I can remember, for 20 years plus, probably more than that. And with good reason. I think there's been a significant focus on getting people insured as seamlessly as possible. But of course, every time you move up a non-medical limit, you're giving up some protective value. Whereas I think things like the remote photoplethysmography, the RPPG, really does give us cause to rethink whether we can embed a very streamlined and non-invasive technique to give us some really valuable biometric data, enables us to give the best price to the individuals, and enables us ultimately to pass those savings on to the broader risk pool. So I think that could be quite disruptive, actually, and it could give us cause to really rethink our upward pressure on NMLs. Back to you, Tim.
Thanks, Gareth. Yeah, I mean, actually, so we've got a few questions coming through, and one of them, I guess, kind of related to this was around, can we really rely on our pilot here, 12-week study, to really be able to tell what long-term impacts we're going to see from this? And that is one of the key things here, is how people will engage from this in the long term. On that, I would just say we didn't really expect that a 12-week pilot would do that, and we're looking at much more sort of wide-ranging pilots to really test that technology. But I guess our pilot was mostly focused on sort of engaging with the technology, understanding the technology, and really understanding how we might use it within a product. But we definitely, you know, as Lisa and Gareth have said, we definitely see some interesting potential here, I think, to streamline the process and bring more data into the process. Simon, maybe I can come to you. I'd be interested in sort of an overview of the additional data that insurers might have that you could integrate into this sort of solution, and how you see that working in practice.
Yeah, thanks, Tim. So I think the capability exists, as I described earlier, for us to be able to integrate with different sources. Insurers sit with information both from a claims perspective as well as interactions with healthcare system that would make sense and add a lot of value and power to the capability that we've already described in terms of the use case and that we built for the pilot. So I think it'd be really interesting to work on that with a potential partner and see what information exists, how easily we could capture or engage that data in terms of our integration methods, and then work with that data to be able to add a layer that we currently don't have.
Fine. And I guess coming back to the sort of long-term nature of the products that we have, I guess one of the criticisms for these sort of engagement models can be that it's difficult to engage policyholders. They buy a life insurance product and they don't necessarily want to completely change their lifestyle as a result of it. They're just not that invested in it. And I guess we've talked a little bit about some of the ways that this could be used where you don't need long-term engagement. And from a sort of personal standpoint, I think there's a lot of potential there where it's sort of more of a one-off health scan, identify the risky individuals, and then do something about that. But in your experience, I guess you've looked at this in quite a number of markets, Simon. In your experience, have insurers had success with engaging policyholders over a longer period?
Yeah, we've seen some really interesting feedback from some of our clients, existing clients of ours who've used it in different ways, Tim. So I think the beauty of the technology that we've developed here is the ability to work with it or use it in different parts of the chain, be it at onboarding, to engage with an applicant in a quick and easy way. Digitally, it's frictionless in terms of the usage and the understanding of risk at a point in time. But then I think more importantly is that ability to, with the policyholder having access to that solution, is being able to generate and self-capture a lot of information that effectively goes missing in the ecosystem. So whether it be your wearable data or the ability to work with RPBG and or other data sets, I think that compound effect of being able to bring that through adds a lot of value to an ongoing policy holder management and interaction. I think, to the point made, certain policyholders will engage with the technology on a more regular basis, others won't. I think from our perspective is we're coming at it from the basis of building a solution with partners that makes sense in terms of their world. We don't want this to be an overarching kind of overbearing thing that you need to do on a continual basis. We developed it and designed it to be super easy to work with and use. It doesn't require a lot of manual intervention or input. So the purpose behind VivaScore is really to be this digital companion that lives with you, that understands and kind of builds your score with you over time, and then translates that into super valuable information. So that's compelling to an end user, but then surfacing that information back to the actual risk process, whether it's through the insurer or into the actual reinsurance world.
Great. And Kelly, coming to you now, I guess you're focused more on the end of the process where you're actually collecting data from individuals in person. And so what is it, so what have the biomarkers and biometrics revealed about ascertaining the validity of some of this health data?
Yeah, absolutely. So I think it's been quite interesting for us because we noticed that as we were taking the real life health data, we were obviously had a significant overlap with the face scanning data, and overall it's very positive. We noticed a variance across biometrics and health or face scan rather was less than 2.7% across measures such as diastolic blood pressure or BMI obtained from the face scan and across into the real life measurements taken by the nurse. So that's really, really positive. And I think overall, the other interesting element that we found out was around the engagement piece again. So the feedback provided by participants was also very positive in terms of finding out new information about their health from the blood test results, for example. So things such as cholesterol, you obviously need to test to be aware of whether or not you are in range, and there are no symptoms obvious to participants as to a high cholesterol level. So what we found from the cohort actually is we had over 60% of the cohort that had an elevated cholesterol, high cholesterol, and that's quite a significant share there. Same thing for triglycerides, quite a significant segment of the population. So overall, the nurse checks were really informative, both in really reassuring about the quality of the face scan and the ongoing digital health checks, but also adding a new layer of understanding.
Great, thank you. So we've had a few questions focused on the underwriting side. So Gareth, maybe if I can turn to you. If I sum up a few here, it's probably pretty much what is the potential, what measures are you looking to use from this face scanning technology, and what's possible with that technology? And then maybe slightly controversially, could this technology actually replace underwriting, or maybe less ambitiously replace some parts of the underwriting? Where do you see it has the most potential?
Yeah, thanks, Tim. Yeah, numerous questions have popped through about the RPPG. I mean, we've been following this technology for probably 3.5 years now. And I guess one of the reasons we've been continuing to follow it is because we get regular updates with the leading providers of the technology that give us increasing comfort around the improvements in accuracy. I would say it's improvements. I'd say there's probably still a little bit of a way to go, which might address some of the questions that we've had so far. And we've touched upon this already, that there's a little bit of work to do to get full accuracy. I suppose there's probably different ways at looking at full accuracy. Well, full accuracy probably isn't really a thing anyway. So even the traditional ways of taking a blood pressure test, there are artifact readings in there. So what you want to do is you want to be comparable if you're seeking the FDA approval on releasing the device as a true medical device. But the other way to look at it is it accurate enough for screening purposes? I think what we're talking about here at this point in time is a screening purpose. So is there enough of a red flag that something could be done, whether that's from an interventional perspective or whether that's from a validatory perspective? So I think that's probably a key thing to draw out. One of the questions really was around what does RPPG measure? And the list is really long. I can't remember all of it off by heart, but I can tell you that it's total cholesterol, HDL cholesterol, blood pressure, systolic, diastolic. We've mentioned already heart rate variability. They've been working on prediction algorithms for things like fatty liver, for diabetes risk, for heart disease risk. There are BMI approximation measures. It's really quite significant. Liver function tests, smoking propensity testing. So it's a really broad suite of tests that are all being worked on and improved month by month. So I guess, Tim, and correct me if I've missed anything else from your question here, but one of your questions really was, could it replace underwriting, and then that was the controversial angle. I don't know that it replaces necessarily, but I mentioned before that there's been upward pressure on non-medical limits for a long time, and this could really give us pause for thought as to whether that's the right thing overall to do in the industry. Because I think here, where you're talking about a 30-second facial scan, the potential to integrate that into a point of underwriting journey is really quite significant if the accuracy is there or close enough to being there that we can at least react from the readings. So I think what this does give us the opportunity to do is actually complement the journey in a very simple way, in a very inobtrusive way, and gives us opportunity to better segment risks and obviously give feedback to individuals who mightn't necessarily know that they are at increased risk. If we look back to that slide earlier on in the scene setting section, where we talked about a significant proportion of people aren't aware that they have established cardiovascular disease. Well, here we could be highlighting to individuals that they either have the potential for established cardiovascular disease or some well-established risk factors for cardiovascular disease or other morbidities. So the potential here to make a difference to society is really quite significant. I hope that addresses most of the questions. We will follow up on any questions we haven't answered at a later point.
And maybe I can just share a bit about the sort of customer and advisor perspective as well. So even if we conclude this is 100% accurate, one of the things that we're learning while we're piloting this with a couple of insurers to gather that data on the accuracy is really the amount of education that's also needed for the end customer and the advisor to start to adopt some of these new technologies. So I think we shouldn't also underestimate the learning journey that we all need to go on to start to embrace some of these technologies where they are shown to be accurate as well. So really having the the clear education materials so customers know what to expect, why they're maybe not having a traditional medical underwriting test. And similarly from the advisor side, I think that's definitely one of the gaps as well that could inhibit adoption of this into the mainstream that we need to be at the forefront of addressing too.
Yeah, definitely. I mean, we know that the trust that policyholders have in insurers is historically and stubbornly very low. And so there's always going to be an element of suspicion with any new technology we potentially bring into an underwriting process that we're somehow going to sort of select against them in some way. So the marketing of that, I think, is really key. The question in the chat around the cost of these things, and I guess we're aware, certainly in the UK, we have a very price sensitive market, and I think that's not uncommon across the globe. Lisa, I guess in the markets that you've seen, is there a way that insurers can sort of cost efficiently deploy these technologies?
Yeah, personally, one thing I really liked about the VivaScore app is it's device agnostic. So we're not talking about funding the cost of a specific wearable device for anyone, but it really integrates with whatever wearable device someone's using, or if they're not using anything, that's also okay. They can use the step count off their phone, they can use the RPPG scan, there's the clinical inputs as well. So that already can make it quite cost efficient compared to some of the other offerings in the market where they are attached to specific devices or specific brands. I think that the key for me would be on the preventative healthcare side. How accurately can we really go from that digital health data, things like the wearables and the face scan, through to getting the right people from that access to the sort of clinical testing that they might need for a diagnosis and intervention. So if you think about our pilot, a third of people took some meaningful behavioral change. If that third of people were the people who were really at high risk, then that would be a way to then prevent, for example, a heart attack or other cardiovascular diseases, things like mental health conditions that might cause claim on an insurance policy. So for me, it's all about looking at how can we use this technology to really triage in a cost-effective way the right treatment or the right intervention to the most appropriate individual who really needs that support.
Great, thank you. And maybe very briefly, because we're almost out of time, a final question. There's a few actually coming through in the chat around, I guess, the use of a wide range of data points and how we integrate those all together to be consistent, and also how we avoid biases. So there was a comment around the adoption of wearable technology is actually perhaps tailing off a bit. So Simon, I don't know if you want to comment there on how you try and integrate all of that.
Yeah, thanks, Tim. So I think really the way we've tackled it is on the one side, from a wearable perspective, is making sure, as Lisa mentioned, that you're actually able to connect into your phone system. So whether that's Apple Health or Google or whatever system you're using, rather than necessarily having expensive hardware, but also being able to use VivaScore across different channels. So as I said, it's web-based, it's app-based. We have a Teams environment. So making that ubiquitous for the end user and part of their world that makes sense. From a data collection perspective, I mean, really our focus in terms of our underlying technology, that Health Cloud engine, is to be able to integrate with disparate data sets. And I think we've done that successfully with a number of third-party and insurers directly. There would obviously need to be a level of compatibility, an API that we could work with, but certainly from our side, it would be something that we would look to integrate into the platform capability. I think the output of that is then working through partnerships like this, is understanding what is the outcome, what are we trying to solve for, what data is important, what are we trying to bring through in a more meaningful way, and then harnessing that data as part of the overall process that we've described here.
Great. Thank you. Right, so we're actually out of time there, so I will draw things to a close. We've had quite a lot of questions in the chat that we haven't managed to get to, so we will follow up afterwards to try and answer those questions and send the answers around to everybody. There is an article that we're publishing today, which, if we could have the Yeah, we've got the slide up, sorry. So if you follow that QR code, or we will also send that around to everybody afterwards. So please do read the article and then also contact us, any of us, with any questions you might have, ideas you might have, or any projects that you might want to run to try out this technology or take any of these ideas forwards. Good, that's everything from today. Thank you to my fellow presenters for your contributions, and we hope that you have found this interesting. Thanks, everybody.
Thanks, Tim. Thanks, everyone.
Thank you.
Thanks, everyone.